Hello, I'm Norman Swan. Welcome to this program on rural health policy into the future, coming to you on the Rural Health Channel. I'd like to acknowledge that this program is being broadcast from the land of the Gurungai people of the Gadigal clan. These are traditional custodians of the land, and we acknowledge their elders past and present. Our program tonight considers the health policies we need for a bright and healthy future for those living and working in remote and rural Australia. Data show that people's health and their access to healthcare deteriorates the further away they are from an urban centre. As you well know, it's not an easy issue to address and faces whoever is going to be our health minister after this coming election. In a moment, I'll introduce our panel to you and you'll hear their views on the policies that have worked in improving health and access to health services in rural and remote areas, and also what ones haven't worked. Are there gaps in rural health policy? And in these times of searches for budget savings, how can we make sure that government continues to invest and that these investments deliver the improvements we need? Now, we need you to join in our discussion. You have greater wisdom than even the great wisdom of our panel. So send in your comments and questions via email, text, phone, or even Twitter. That's how modern we are. The details are on your screen now. You can email your questions to questions@rhef.com.au. You can call us on 1-800-646-015 or text us on 0408 408 932. And tweeting, you can tweet us at Rural Health Ed using the Rural Health hashtag. Now let's meet our panel. Alison Fairley is a vocal advocate for better mental health in rural Australia after experiencing firsthand the impact of suicide in her family farming community. Welcome, Alison.
Thanks, Norman.
Alison's also the 2013 Rural Industries Research and Development Corporation Queensland Rural Woman of the Year. And to continue our theme of women who are incredibly busy, and one wonders how they have time for any other life, is Jenny May, who's a general practitioner in Tamworth and a passionate advocate for a life in rural medicine. Welcome, Jenny.
Thank you, Norman.
Jenny teaches at the University of Newcastle. She's chair of the Rural Doctors Female Doctors Group, is a previous chair of the National Rural Health Alliance, and more. Human rights campaigner Tom Calma is the patron of the Rural Health Education Foundation, our host this evening, and the incoming Chancellor of the University of Canberra. Welcome, Tom.
Thank you, Norman.
Tom sits on the board of many organisations to advocate for improved health for Aboriginal and Torres Strait Islander people. And last and certainly not least is Sabina Knight, who's director of Mount Isa Centre for Rural and Remote Health and has worked for many years across central and outback Australia as a remote area nurse, advocate and academic. Welcome, Sabina.
Thanks, Norman.
So welcome to you all.
Thank you.
So let's start with mental health. Just let's get some of the data on the table. What is the situation when you look at rural and remote Australia and the data on mental health and mental health issues?
Sure. Well, particularly for our farmers and our agricultural workers, we're looking at a rate of 20 to 30% higher suicide rate than the average population. And this is particularly prevalent around the age groups from approximately 29 to 59. And we also see a significant increase in men over the age of 70. So we need to have and look at the enormous fracture that suicide causes in our rural communities.
And does that reflect, given that there's a disconnect between suicide and depression, we'll come back to the services in a moment, is that reflected in depression and anxiety rates?
Not necessarily. You cannot link suicide particularly to mental ill health. We've seen rates of depression and anxiety increase, particularly around issues related to economic and profitability, increased rates of
when times are bad and people are losing their farms.
Exactly. And we see undiagnosed issues around post-traumatic stress disorder related to drought, related to floods, related to cyclones, etc. People's access to services, as we know, is much limited though, and their ability to understand what's happening to them is related to a lower level of literacy around mental health. So we'll probably discuss a lot more about that this evening on the panel, but it is significantly
Tough guys
less.
don't cry.
Exactly, yeah.
Jenny, what's your perspective on the data and what the facts of the matter are?
The data is improving, most certainly, and certainly from
Sorry,
the point of
the
view
statistics are improving or the quality of the data?
Well, I would like to think that both are, but what I would suggest is that the current state of play is that we're getting quite good aggregated national data around things like health outcomes and risk factors, but we're still not bringing that down perhaps to a local level and getting regional data of sufficient quality to be starting to make decisions around. But I think the other thing that I would caution is that if we're thinking about data and health outcomes, how longitudinal do we have to be? Because certainly we are benefiting from the healthcare and services and social disadvantage that occurred 20, 30 years ago. And rural Australia is markedly different, I would suggest, to that 30,
so is
30
life
or 40 years ago.
expectancy less?
So life expectancy is somewhat less for a Caucasian male in Australia.
Living in regional, yes.
Living in regional Australia, it's certainly lower.
It's anything from 25, 30 years to 7 years.
Right, and obviously, Tom, there's still the ridiculous and tragic gap.
Yeah, well, the gap and it does vary, and by location, we know that people in rural areas and remote areas probably have a shorter life expectancy than people living in urban areas, and there's a whole range of factors about that. When I wrote my report in 2005, which led to the Close the Gap campaign, it was 17 years. It's now been revised to about 12 years on average, but what we're seeing is...
And as Sabina said, some places it's going to be much bigger than that, some places less.
But whilst the gap appears to be closing, we're also seeing that the life expectancy of non-Indigenous Australians is increasing, and so the gap's still there. The gap is still there, and it's a real issue. But when we get back to the issues that Alison talked about in relation to suicide, it's you can double that plus a bit more for Aboriginal and Torres Strait Islander people. It's a real issue, but I think one of the things that I always like to caution people about statistics, and some people are really driven by statistics, but we must remember that they represent a family member, a loved one, and we can't just be driven by statistics. We've got to look at the whole social circumstances, the life circumstances of family groups, of communities.
And just talk us through this graphic that's up there at the moment.
Right, yeah, it's a graphic just showing the difference. The darker peaky colour represents Aboriginal and Torres Strait Islander people by state, and the purpley colour is the non-Indigenous population. And you can see there is by location, by state, it does vary, and it can vary quite significantly. And once you get into some of the places like the Northern Territory, which is not a big population but a very sparse population, except for the Alice Springs and Darwin sort of centres, it shows a real issue, and it gets back to what Jenny mentioned about access to services, and the provision of services is what we need to check out. But it is a real issue when we look at suicide and mental health. It's very, very prominent in Aboriginal and Torres Strait Islander population groups, and that's an issue that we have to look at because there's no common reason for suicides, and there's also no common solution. And so it's about how do you empower the community to understand a bit more, to be able to work on some of these issues. How do we make our health professionals and paraprofessionals much more aware about some of the indicators that might lead to suicide? And it's not always about depression and anxiety, it could be anything. So we've got some big challenges out there, but it's starting because only in the last few months we've seen the first Aboriginal and Torres Strait Islander suicide prevention strategy being launched, and that's after a lot of consultations, a lot of feedback. So it's an important area.
We're moving. Sabina, the data.
Yeah, the data, as Jenny said, is hugely variable. We have begun to have some apples and apples comparisons in Australia, but we've not got it down to the granular level where it's really useful at the regional level yet, and that needs to be improved. There is some...
So you don't know whether you're making a difference or not?
We know we're making a difference in the big picture, but within regions, it's hard to tell. And I think that's the trick. So when you talk about rural health or remote health, you want to understand your own variation.
So what's the contribution of lifestyle versus access to, in non-Indigenous communities, to the life expectancy gap, which is probably the crudest gap that you can have, but look, for example, cancer mortality is higher in rural areas, thought to be because it's diagnosed later. Which is an issue for general practitioners. Are they missing it?
So some of that's behavioural, late presentation, not paying attention or noticing things. Some of it is in the options of treatment. There's some good evidence coming through around the chronic disease rates and the responsiveness of that to access and treatment, and we need to watch the literature for articles published in the next couple of months. And if we focus on the things that influence our life over time, it's really important to have a healthy start to life. And so if we look at this graphic where we've got low birth weight babies, look at where Australia sits compared to the rest of the world, and then you look at where Indigenous people in Australia sit compared to the rest of the world. And rural and remote areas would fit somewhere between those two. We know smoking rates in pregnancy are unacceptably high across the board in rural areas. We haven't, alcohol in pregnancy, nutrition is still right across the board in rural areas and remote areas is something that we're concerned about. Doesn't mean everybody drinks, but it means that we've got higher rates than the rest of the country. So our public health penetration's lower.
Don't forget to make a comment or ask a question. We welcome your comments and questions. The number to call in on is 1-800-646-015. The number to text us on is 0408 408 932, or you can email us at questions@rhef.com.au. Jenny?
So Norman, if you have a look at the slide that was recently, or it's alluding to a recent COAG report, which tries to unpack a little bit around what's socio-economic disadvantage and what's rurality, and I think that's what we're talking to, and surely that's crucial. And what it
Let's have a look at that graphic
suggests
now.
is that if we look at smoking rates for those with socio-economic disadvantage in an urban area and in a rural area, you'll see a difference between 21% and 30%. But even more stark is in terms of at-risk alcohol consumption, and you'll see it in a lower socio-economic decile in an urban area at 12.7, jumping to 22.3 of our rural constituents. And I think the impact of alcohol in rural and regional communities is something that most of us have experienced and are seeing being incredibly destructive. So I think therein lies a challenge both to politicians but also to the health sector, is how do we unpack that and what can we do that specifically impacts on that rural and remote sector? Because obviously the prevention campaigns that have been used for mainstream, I mean, I'm thinking particularly about smoking, are not impacting nearly as effectively in both Aboriginal and Torres Strait Islander Australians and also in rural and remote.
Sometime on the week of the 15th of September, the new government, of whichever colour, will announce who is the health minister. And what are we going to say to the new health minister in terms of the good news? What's working out there that you shouldn't axe? Alison, in your area?
Well, from my perspective, one of the programs that's been exceptionally beneficial has been the Rural and Alive and Well program that's in Tasmania. Now, that came out of an industry organisation called Sheep Connect. These sorts of programs are ones that are born from a community, they're locally based, they're regional, and they have ownership of the program, and therefore we have seen a significant drop in the suicide rate amongst rural Tasmania where this program has been rolled out.
The message is that works, so spread it through the rest of the country.
A model like it. We cannot have a one-size-fits-all. We know that. We have to have regional solutions. And we've had a robust debate about this. The fact that we have a top-down approach that comes from many health policies simply doesn't work in our rural communities. We need ground up. We need people to have ownership of what's happening around their local needs. And this is something that I really want to see our government focusing on.
Jenny?
Can I suggest that it's difficult to nominate the policies that are really working well, because there's lots of things that are really working well, but I don't know it, because it's until the practitioner leaves or something happens and the program goes and I suddenly go, there's a hole. But I think in essence, in principle, the programs that seem to me to be working well are those that integrate best. So for instance, the MPS program, where you're integrating aged care and acute care within small rural communities.
MPS?
I think MPS, multiple purpose services. I personally see those as extremely effective ways of delivering services and building community capacity for healthcare in a community. So I think that's that's one thing that I think we can all look to and see as a potential model to be built onto the future.
So just hold the thought for a moment. I mean, that's where you work as a multi-purpose centre.
Yeah, well, I work in the University Department of Rural Health, but the multi-purpose services surround me. So they are the very small rural hospitals or remote hospitals that also do aged care, also.
But Mount
do
Isa had
primary
one of the
healthcare.
first, didn't they?
They were very early off the bat, and one of the last, in fact. I mean, Julia Creek is now being established, and so multi-purpose services are really important. And I think where these work is not in isolation, but they worked where there's a raft of activities that help people understand how to plan their services and evaluate them. And I'd say the other program that's really worked in this area when we look back is the providing the evidence base for the future and understanding. So the University Department of Rural Health program has been hugely successful. Before it started, I think there was some of my colleagues did an analysis, and I think there were about 75 articles published in peer-reviewed journals about rural or remote health in the titles, and that, of course, now there's thousands and thousands. And so we've got an evidence base, we're growing an evidence base, but importantly that evidence base is around issues that are important regionally as well as nationally.
Getting back to the MPSs, what are the lessons we can learn about programs like that are likely to have good utility in rural and remote? It's about blended funding. That was a combined funding program where everybody had to put their skin in the game.
So did they cash out Medicare?
Yeah, well, they cashed out partly Medicare. I'm not an authority on the actual, but I know that all three areas of the department have been involved in some of the negotiations, and obviously Aboriginal and Torres Strait Islander models have come through the same way.
Fragmentation.
Totally. So skin in the game. I mean, that's what it is. Decent governance. All right. Most health professionals want to work in a place that's well governed, and increasingly we are seeing these.
What does that look like?
Principles. Well, it's alive and well, Norman, and I think there's some excellent opportunities to look at.
But so tell me what it looks like when it's right.
Well, when it's right, you've got leadership. You've got teamwork, you've got true involvement, you've got a reasonable funding model, and you've got an interest in succession planning and support to workforce.
And you've got accountability
and you've got community
because
involvement.
you report to your community and you
So I've
report
not heard
to
a
the
word about the
stakeholders.
patient yet. So the organisation works terrifically,
Okay,
and then it's
good.
really annoying because the patient walks in the door.
No, okay, fair is fair. I get that, and that should be implicit in what I've said. But yeah, no,
I mean,
you're
are
right.
outcomes better for people and families going into an MPS compared to traditional services? Do we know that?
They get integrated care. They have
well, that's great. But is it better?
Better health records, but coordinated, because it is the one place they go for health care.
That's the mantra.
Not many.
I'm now being the health minister, being cynical. You know, that sounds great.
Well, that's a good question.
Textbook answers. Are you making the slightest bit of difference? Or are people sitting in meetings all day working out who they're going to look after?
Okay, Norman, I would suggest to you that if there hadn't been MPSs, there would be actually an absence of some of those services. So MPS has been the only way to actually continue, for instance, providing some acute care services. So if you're talking about a comparison between nothing, I can guarantee it's better.
Good. What else did you have on your list of things that we're working for? I get to young Tom.
Yes. Look, I think there are some big lessons to be learnt in a program like the Medical Specialist Outreach Program, and for many rural clinicians, that's been an excellent program. But again, it's been
just fly in, fly out for specialists.
It's the seagull idea, but I would suggest that it's best put in regional centres. So if you've actually got fly in, fly out, hub and spoke models that actually speak to
So instead of coming from the major capitals, they're coming from regional centres.
And they are grounded and integrated in terms of ongoing care. So you've got continuity of care, and you've got the fact that when you get crook, you're actually medevaced back in. So for instance, in terms of obstetric outreach, how much better to have the obstetrician and the midwife and the ultrasonographer come out and see you in a high-risk clinic out in Moree, and then see you for your confinement in the fullness of care.
So we just had a question from Tiana Manchu from the National Australian Pharmacy Students Association about the recent changes to the FARIA system, making it harder to afford placements in a rural setting, talking about bringing workforce to the bush. Do any of you have any comments on that?
Well, perhaps if I could start, and I mean, I think this question in many ways brings us to another success, which is the concept of bringing students out to rural areas. So positive rural undergraduate exposure, we know, is correlated with rural retention. It's not the whole story by any means, but it's a good start. So I mean, the fact that there are programs that bring students out is terrific. at some level we're going to have to make some difficult decisions about who we target best in that program. Sabina, your sense of it?
Well,
So what you're saying is you only want to target students who are going to stay in the country?
Well, I'd like to target students best that came into country. I'd love everybody to have a great experience.
Do you know one when you see one?
Well, I mean, I'd suggest to you that there are many, many students who go to rural clinical school now because it's such good generalist education. So they're going, oh, this is excellent. Do they have any intentions of staying rural and remote long term? No, but it's excellent training. So we've got there, and part of it is improving the status of rural health. We're not second-rate cousins, and rural students can be as good or better than their metro counterparts. So we're succeeding at that level, but
So-
there is a
So
funding
what about
issue.
this question about the reduction to the farrier
So
system?
this is a case, I think, where we may be a victim of our own success. So pharmacy programs are now producing enough graduates to soak up the workforce needs in the metropolitan areas, or come very close to it. And so the funding bodies made a decision to alter the funding guidelines to only provide the rural placement funding to the pharmacy schools that are sending students to the outer regional rural and remote areas. And so we're going to have to gear up for this. As we get more successful, we're going to see changes in grants. And so one of the things we've recommended is that whilst we accept buckets have to be changed, that for those students who are very passionate about living and working in rural and remote areas and really want a positive rural experience, then maybe a scholarship scheme could be made available to those attached to where there is guaranteed quality experience. So where there are accommodation, support, supervision, mentorship, like they do through the clinical schools and the University Departments of Rural Health. One of the big issues here is about end-to-ending the pipeline, and so we know getting the rural origin is important. We know giving the rural experience is important.
If it's positive.
If it's positive and long enough, it needs to be long. It also is very, very
So we're
important.
talking 3-month secondment to a rural term, just forget about it, it's not worth it.
Well, I don't think not forget about it, but it's clearly making a big difference where you have those long rural intern placement experiences that
So
are
understand what
positive.
you're achieving here. If it's a rural placement just for clinical experience, that's fine. But
Yeah.
if you actually want to
Immersion.
recruit and retain for the country, it's got to be a year or two.
Yeah.
More longer immersion experience.
And if you then bookend that with getting a job when you graduate outside a metropolitan area, you're starting up the ante of they're up to 10, 15 times more likely to be 5 years after graduation working outside a metropolitan area. That's the data that matters.
And is that a gap?
Yes.
Yes.
The
So
jobs
the
aren't
career
available.
pathway at the moment, there are some disconnects from people completing rural clinical school or similar time.
So is that because we don't have enough salaried PGY 1 and 2 in medicine?
Partly, but it's because obviously our larger numbers of medical students are now coming through the system. So it's partly about placements, but it's also partly about connectedness. So at the moment, if you wish to do anything other than general practice, you really have to spend a significant amount of your time back
So
in
the specialist
metro.
training is...
So specialist training, there are some really good programs out there, but the connection and the development of a pipeline that pulls through, that equips people appropriately for the skills that they need as a rural generalist in the community, we're getting there, but there are some gaps.
So Tom, few people have got your history in this area for the length of time you've seen things happening. What is starting to work, what is working that needs to be kept and sustained?
Well, I think the real success has been the Close the Gap campaign, where we've got Indigenous and non-Indigenous peak bodies working together at a governance level, trying to orchestrate so we get realistic policies and to be able to influence government through advocacy.
So my challenge to you on that is the same as a challenge to Sabina. Sounds great. Is it actually making a difference on the ground?
Well, it is making a difference. I think firstly because we're talking with one voice now, and that's a very important one that hasn't happened in the past. It's also enjoying at the moment bipartisan and multi-party support towards the Close the Gap campaign and the statement of intent. But we're also seeing the Aboriginal peak bodies working together with the National Congress, and so there's the two layers. Firstly, the layer of governance and getting that right, and I think that's progressing. The second is the programs and the engagement. If we look at groups like the National Aboriginal Community Controlled Health Organisation and their affiliates are really starting to professionalise a lot more, delivering services. We're seeing increased numbers of people coming in to get access to services, because you can't increase access if you don't have the opportunity to access. And so we're seeing that now. We're seeing in some of the services where they're becoming much more culturally competent and much more welcoming, and I think that gets back to the earlier question.
But Tom, what's going to happen with the things that really make a difference to life expectancy and closing the gap, like education and housing, rather than, it's great to have good culturally competent health services, but they're only going to really scratch the surface.
They will scratch the surface, but the issue is you need to get people into the service firstly and get them to come back, because the issue is, particularly in rural and remote Australia, is that people are very late in diagnosis of a lot of their chronic diseases, which leads to issues of not being able to address them. But through a whole range of preventive health, we need to get into a lot more population health approaches. If we look at smoking as an example, tackling
close to your
smoking,
heart.
Very close to my heart. It's an issue that has started, and this is the whole challenge, I think, for governments and whoever is in government and oppositions to not try and politicise Aboriginal health, Aboriginal and Torres Strait Islander health, but to see it for what it is. It needs to be addressed. It needs a bipartisan support, and it needs.
So smoking doesn't have bipartisan support?
Well, it depends who you're talking to within the parties.
Doesn't have
Smoking reduction, yes. Look, some members of all parties support it, and some are opposed to it. But it's a challenge. Look,
So remind us of the pillars of the smoking reduction strategy in Aboriginal communities.
Well, just over 50% in some of our rural areas of people smoke, compared to under 20% within the general population.
Mind you, a few years ago it was 70%.
It was 70, yeah. In the 40s, yes, we've seen a reduction, but as Jenny had mentioned earlier, the mainstream programs haven't really resonated with people living in remote areas, Aboriginal and non-Aboriginal, and so we're taking an approach now that's really working closely with the community and empowering the community with knowledge about the health impacts and the economic impacts.
But they've also not had the role models. In non-Indigenous communities, by and large, doctors don't smoke, whereas there's quite a high rate of smoking amongst Aboriginal health workers.
There are, and there's quite a number of non-Indigenous people who smoke as well in the health profession. But small changes like doing health professionals doing brief interventions when somebody walks in to take a record of whether they're a smoker or a non-smoker, ask them the question, refer them onto quit lines or other services. That's not common across all the services.
And we're talking, this could be 6 or 7 years of the gap if you just got rid of smoking.
6 years, yeah. It's estimated to be 6 years, and so it needs a combined effort. And what we have, and numerous reports to governments are showing that the biggest impact on Aboriginal and Torres Strait Islander affairs is the stop-start of program funding, policy directions, politicians' own personal interests in these areas, and we need to really address that if we're going to make a difference. The programs that are starting now should be able to be seen through a decent life to make a difference. And
the other thing I hear constantly complained about in community-controlled organisations and Aboriginal and Torres Strait Islander service organisations is that they feel they're held to a higher level of accountability than non-Indigenous services, and almost cripples them. The number of people they've got to employ just to keep white bureaucrats happy.
Well, no, and that's been addressed over the last couple of years, and we're seeing much different structures within Department of Health and Ageing in the way that they're funding, with the head of agreement and then a number of schedules under it versus the multiple 60, 70 different funding streams in the past. So that bit's being addressed. Governance within the organisations is improving, and it just takes, I think, a bit of time. But the worst thing will be if we change direction again when people, and this is about when we look at behavioural change, irrespective of who we're talking about, that takes time and it takes a lot of effort. And you've got to be consistent in the sort of information you provide people to allow them to make an informed choice. And then that partnership, the collaboration between the health professional and the client is paramount, and that takes time to develop. And when it is undermined, then you lose any momentum, and you've got to start again, and that's not good for any population group.
Sabina, do you want to add any other good news stories that need to be sustained?
Well, I think one of the good news stories for me, when I look back, is the sustained focus on rural and remote health in the policy agenda over the last 15 years. So, you know, I go back to the formation of the National Rural Health Alliance and the early days, the involvement, the skin in the game in developing rural health policy, in having a go, getting it right, getting it wrong, readjusting, so people feel like they've got an investment in the future and therefore are more willing to collaborate and work together, and find they've got more common ground, probably more tolerance for the long term and the time it takes to get change. And I think now that we're getting better data, even though we're not happy with the quality of it, people can actually see where we've come from and where we're heading to. And so I think there's a lesson in that this takes a long time. Yet we're making big gains in Australia, and the gains aren't anywhere near as fast or in rural areas. So there is a lag, and we're falling behind, and we need to develop different and targeted strategies. At the same time, there's this real amnesia around what works and what doesn't work, and I think we have to remind ourselves we have to work.
Let's move on to that. What would you stop? What's not working? Waste of money. Get rid of it and redeploy it into other areas.
Well, I'd certainly stop the pilotitis, the short-term programs that are never going to get refunded. It's good to test new ideas, but don't build a health service model on it.
So be committed to spreading. So the Tasmanian example that
but don't make
Alison
it so you have to do that model everywhere. Have that idea that can be customised and grow in response to your
Okay, no more
region.
pilots, got that.
And the other is the not relying on a market model, a business model for small, rural and remote health services.
So what do you mean, contestability?
Contestability, so funding many different providers. So we've got the seagull effect, so we know seagulls don't do well in the bush. If we rely on the small business model, so in generating Medicare to run, for example, a comprehensive primary healthcare service, of course it will fail. We know that the translation, the exchange rate for the dollar, the Sydney dollar to Mount Isa or the Sydney dollar to the Kimberley, the purchasing power is dramatically different, and so the money it costs to, the investment required to run good services is different. And if you keep focusing on trying to raise money through business model, we don't provide good services, and so we need to stop trying to do that whenever we try and roll out a new model for which it is attractive
So
to try
what you're saying,
and
government's got
leverage.
to take it on the chin.
It is, but I think we've also got used to accounting for the presence or absence of services through Medicare utilisation, and I think that's useful in some areas, but it's not useful as being the only lens to look at things. And so, you know, I think we need to be careful how we do that, and to.
But of course, Jenny, the AMA will die in a ditch over this one.
I think the AMA is committed to seeing good services in the bush, and I think the AMA has
But
demonstrated.
they're also committed to fee-for-service, which doesn't necessarily work in that model.
I think they're committed to fee-for-service where fee-for-service works, but it's been well demonstrated that the viability of rural practices is poor, and therefore we need to look to blended and other funding models, and I don't think there's any argument about that.
So Tom, what would you stop?
Well, I'd try and influence the way that we're still having the siloed effect within departments, and there needs to be a greater collaboration between portfolio agencies when we look at health, and too often we just focus on Department of Health and Ageing or the state and territory departments of health, and thinking that they're the only ones that fund health, when you've got a whole range of other departments out there who are putting money in, and too often it's uncoordinated. And I think there's enough money out there. As to how do you maximise the benefit from that money? And so it's picking up on one of the issues you mentioned earlier about education, employment, the social determinants, and the cultural determinants that are here. And we've now formed a social determinants alliance of peak agencies, which is now looking at these issues.
Peak non-government agencies or peak
non-government agencies? Yeah.
Right. So how are you going to whip the government into shape? What are you
Well,
going to say to the health minister?
That's what advocacy and partnership's about: collaboration and respect, and that's what it's about. And I think this is what bureaucrats need to start and continue, as well as politicians, to listen to the health professionals and the peak bodies, and make sure that the advice that they're providing is heard, because we're the ones through our agencies have the direct contact with the community, and so it's feeding up those issues, and it's improving, but we need to see it develop more.
So Jenny, what's not working? What would you?
Well, I mean, I think just taking on from what Tom said, I think we've got to have skin in the game as rural health professionals and own and be accountable for both the access, the quality and the outcomes that are coming from our services. And it has to be said that they're patchy. Some of us, and in some spots, are doing really well, and some of us are doing less well. But I think the other thing is
but to know that, you've got to measure what counts.
So, exactly. So you've got to decide whether you're going to be measured on outcomes or whether you're going to be measured on a group of proxy indicators or as I said, do you look at what the principles of a service, a good service are and try and measure them? I mean, this is a huge debate. But I think the other thing, just taking up from what Tom was saying, was about maybe we stick with the investment we've got, but we target it better. And as I said, in terms of the rural pipeline, the feds are actually putting money in along the pipeline, but there is a discontinuity. So surely it's a matter of simply retargeting and refocusing some of those investments.
Alison, let's move on to health priority areas and look at mental health.
Yes.
And the sort of you've got 5 minutes, or in the case of this program, 30 seconds, to convince the health minister of where strategic investments could be made, apart from the spreading of that successful story in Tasmania you told us a little about before. But what are we going to do about this? We've got increasing rates of mental health problems.
Yes.
And they go up and down related to the economy, but they're there all the time. What are we going to do about this? What's the policy setting?
Well, for starters, we have to move away from a model that says if you build it, they will come, because they won't. In rural areas, the majority of for example, our farming and fishing population don't access formal mental health services. They're aware
so
that
forget about the ribbon cutting for the new mental health centre.
In essence, we need to ensure that we've got mental health professionals placed into our communities, yes, but we have to improve the model of how people access those and the information that's shared. There is still so much stigma in our rural communities into accessing these mental health services.
So are you asking for outreach, for people
going
to people's homes?
Yes, I'm asking for on-the-ground outreach programs, social workers who can go into homes and visit people on a needs basis.
This could be the answer for the FDBT problem in cars, because you're actually going to buy Australian cars to get these mental health workers around.
It could be, but of course...
I think this could be an angle we could work on here.
Of course, we have to look at that, though, from a financial perspective. And we also know, that our rural areas are huge. The expanse is enormous.
You're not seeing people, you're spending your time in the car.
Yes, you're spending your time in a car.
So is technology the answer?
Well, we have to use technology to support these people, and we need to use it wisely. We cannot use it as the answer, but it's certainly a part of the solution. And I would really love to see, a lot more emphasis in ensuring that our rural communities are serviced through a supportive technology framework.
So what would that look like? That sounds great jargon. What would that actually look like?
Fibre optic network for starters would be wonderful. We're seeing some major regional areas like Townsville, where I am.
So do you think if you're, you've got a farming couple where the wife knows that her husband's in strife, and they're 200k out of town. So it's going to take that worker a day, of their lives where they're not seeing 20 other people and just going to see one person. Is Skype a solution here, and will farming families use it?
Look, evidence so far is telling us no. Evidence is telling us that male farmers and agricultural workers are not accessing the telehealth or online or even telephone helpline services that are available. They're still looking to their local GPs for information sources. However, that Skype service can be used to support the wife, who then is supporting a husband who is in trouble, to maybe get in touch with a mate who can come around and have that chat out, at the cattle yards, at the back of the ute, where men talk. People say men don't talk, but men do talk. They talk in a different circumstance, a different setting. We have to support our communities to be able to support the individuals to do this.
So my question is, if the funding was at that primary healthcare community level, could they then sort in the services that they require to support that? Because at the moment, obviously, the funding
So who do you give it to? The Medicare locals?
Well, If they're local enough, yes. I mean, I guess that, you know, when the Medicare local is a whole state, then that's...
Yeah, but that's only Tasmania, really.
Well, okay. I certainly think that we need to acknowledge communities as different looking things with catchments and ways of relating to each other. So it might be that
I'm getting an abstract feeling here. So I'm the health minister and I'm feeling a little bit uncomfortable because I'm not quite sure what I'm going to do my dough on. And I might do my dough.
Well, you might, because if you actually empower communities and at the level of Medicare locals, then you will lose some direct control. You will retain accountability, but you will lose direct control. Is that a fair comment?
Yeah,
Yes.
and I think we've got to
So you've got to be prepared to give up control to get success at a local level. Is that what you're saying?
Well, I wonder if that's not, I mean, significantly, if we look at the social determinants, one of the social determinants is empowerment and you know, being part of it. So from my point of view, if we're actually going to improve rural people's health outcomes, then empowering them is part of it.
Yes.
Sorry, Tom, I interrupted you.
No, I was going to say we also have to be a little bit creative, because I think whilst in general terms men in rural properties aren't necessarily getting onto some of these helplines, most of them on big pastoral properties and other farming areas do hook up to their farming apps. And so it's not always about the health minister, what they can do, it's about other ministers and how they can maybe invest into you know, Farmers Federation or whatever to be able to create some health information on the medium that the men work with. And you could, you know, it's not inconceivable to have a you know, a virtual men's shed out
Which
there.
in fact some people are actually
Which we are,
doing,
and our
working on.
agricultural field days, those are the sorts of activities that Medicare locals are in part of.
Now, I've got a question from Yvonne Luxford of Palliative Care Australia in Canberra, you know, about palliative care workforce, and how do we build the skill set of the generalist workforce to actually do palliative care? Do you want to pick up on that, Sabina?
Yeah, I think the further remote we go, the more important that it is that the workforce is generalist. And one of the specialist skills of a generalist is being able to bridge care, being able to network, in this case with palliative care specialists, to be able to provide really good care.
Well, we failed
at the local
miserably
level
to get general practitioners to do palliative care in Australia. So we're going to have a more generalist workforce. So there's a lot of things to be said for that. But we failed to get generalists to do palliative care, particularly in the fee-for-service system.
In the fee-for-service system, we're right, because we haven't, in our current financial models in the fee-for-service system, does not reward or incentivise or support care over time. And so if we could bundle care to engage general practitioners in palliative care, then we would be more successful. But in small rural areas where GPs are providing care to both community through practice and their small hospitals, they are engaged in palliative care. They're very engaged in palliative care, and that's my experience. And as are the rural nurses and the remote area nurses.
Yes.
So the smaller you are, the more likely you're able to get it. But it is important that, so this is where speed becomes important, the NBN or fibre optic or whatever. It's really important to get reliable, speedy access to the information you need and to the teams you need to get
So to have a
from.
palliative care consultant on
Absolutely,
tap to say,
on tap.
I've got this difficult problem with side effects, what am I going to do?
Yeah, being able to, you know, if you're in a small place and you only have a couple of cases over the year, you're not full bottle on that, as you're not going to be on renal and other things, but you're going to be across a wide range of areas. And so you don't want to rely on your own memory. You want to ask the specialist or get advice from them. And there's some of this is in the forecasting. So what do I need to be prepared for? As a team, what do we need to be prepared for? What drugs do we need? What aids do we need? We can plan ahead. We have some unintended consequence or a course of events that we need some support from. We can do, you know, a telehealth consult with the expert, get the advice, and then provide the care locally. We're seeing quite a bit of success with tele-oncology in northwest Queensland. We've got an oncologist team out of Townsville that's providing all their support by telehealth, which is radically changed our access. And we're moving on now to telenursing, which means that the chemo nurses, who are the experts and the specialists in the oncology and in Townsville, in the room with you via the teleconference to people like myself, if I was the nurse, or other nurses who are in the small rural or remote hospitals, but working together as you would, checking the drugs, providing the chemo.
Tom, I'm hearing this recurrent theme about devolution, trusting people on the ground, and getting
and empowering people. And I think
so is it the same with drug and alcohol?
Yeah, and just on the palliative care, I think that PCA have been doing a fair bit of work in the Aboriginal space in the last year or so, a couple of years probably, Palliative Care Australia, and to try and understand how to best provide us support. But through the Poach Centre at University of Sydney, where we have fly-in, fly-out specialists going into our communities, a lot of the emphasis is about empowering the communities on pre and post visits, so how they can maintain the service and support when the specialist is not there, and creating that partnership between the visiting specialist and the hospital they work from, so that people can get quick referrals.
So it changes the nature of the specialist visit. So rather than necessarily seeing patients, you're about upskilling, passing on your skills to the local team.
And that's what I was suggesting, that if the want and the need comes from the community or from the primary care establishment and they get the care in, they'll get more of that longitudinal care because that's what they want.
So not seeing 40 patients in a day.
That's right, they actually want
weeks.
to be supported and they want the service that's visiting to get context because that's what we work in. That's our currency, is context. What they've got is expertise. So matching them together makes the difference.
Yeah, within that cultural context, and that's not only about Aboriginal and Torres Strait Islander people, but it's a culture of people living in rural and remote Australia, which is very different to an urban-based culture in many ways.
So we've had a question from Julia Hardacre about animal management in rural and remote areas, particularly dog health and zoonoses. And when are we going to resource this properly, and what sort of burden of disease? You're looking at me as if I'm mad.
Well, I have to be honest, not my area of expertise, but I think there are certainly some principles there. And as I said, if we go back to the social determinants, there's absolutely no doubt that if we have a situation of overcrowding and large numbers of animals, etc., then it's going to impact very adversely on long-term health outcomes.
Yes.
So it's definitely part of the picture. How you fund it appropriately, I wouldn't
it's a big issue in some Aboriginal communities.
Well, in many Aboriginal communities, and the Environmental Health Association is, their conference every year tries to address this issue. And what we're seeing increasingly is that it's the voluntary sector who are out there providing support in animal sterilisation and other programs. And so, any additional financial support in a very concerted program would be welcomed.
It's a good question, Julia. I think that the link between animal and human health and the interaction is really important in rural Australia. We've got all sorts of conditions we're concerned about. There's Q fever. We worry about sort of animal or insect transmitted diseases like encephalitis up in the Strait.
Chikungunya.
And climate change is going to impact on that.
Yeah.
And in fact, one of the things that we do in our area is that we place vet students along with all the other health science students because we want them to get to know each other really well, because it's often the vets who are better at public health or health promoters to people who are harder to reach, because the farmers and pastoralists and other workers are much more likely much more likely to ask the vet for some advice. I've been there, seen it happen, then go to town and talk to a doctor. And so
globally it's called One Health.
It is One Health. It is One Health, and it is about as a team and providing healthcare. And I think if you've got sick animals in proximity where humans live, then clearly you've got poor human health. So it's a proxy indicator.
So the question from Julia is, what's the policy piece here, and what's the investment that needs to be made to actually sort this out?
This is not one size fits all, because it depends on, I don't know if Julia's still working in Central Australia, but there's been a lot of work done with dog programs in Central Australia in treating canine scabies, in treating worm infestation, in trying to manage fertility, because you treat those two things, fertility rate kicks up, and managing the numbers of dogs, and working with communities around dog control. And fertility control, and that's the comprehensive program. So it's not a matter of just using ivermectin to treat the worms, for example. It is about having a comprehensive program. So the policy response is, as part of a comprehensive primary health care program in remote areas,
You've got to think
animal
about
health is
animals.
important.
Yes,
And,
exactly.
and this is, primary healthcare services and communities have got quite a bit of experience in this, and if it's funded within the comprehensive package, people have the ability to deliver. And certainly the vets in the area have the experience to support such a program. They're great at being
If you have them.
specialist support by by distance. I mean, the vets are one of the things that are quite happy to talk to you on the phone.
So Jenny, what's that?
I just wanted to, I'm aware that time's passing, and I just wanted to reflect on the absolute need to train the team. And certainly when we're
So
thinking
first you've got
about...
to have a team to train.
Correct, and with that, with the University Department of Rural Health and Rural Clinical Schools, we have again at the beginning of the pipeline, a reasonable supply of motivated, appropriate allied health professionals. But my question is, do we have infrastructure in rural communities, and do we have jobs at the end of that line? And at the moment, I have to say that we don't. I have a raft
For
of
allied health.
speech pathologists, for instance, in my local area who haven't got access to jobs. Now, they would move to those locations, but there are no jobs.
So they can choose to go into private practice, but that's not necessary.
Correct, but we know that the viability of private practice once we move past inter-regional becomes dicey. And if we look at the slide, you'll see similarly distributed to general practitioners, the slide towards very remote. And yet those people who work in outer regional, remote and very remote are the people we need more skilled up than those metro, because we're asking them to provide very generalist
So
scopes
tell me
of
the
practice.
solution.
Well,
Who's going to fund the jobs?
I think, and it's not only the jobs, what I think we need to do is get our heads around, if we're going to have workforces in rural communities, we're going to have to provide infrastructure in terms of housing, and we need to acknowledge that general practitioners and nurses and other members of the team are also not going to work very long hours. So we're talking about building 10 houses in a town of 6,000 to support the health professional workforce. And I don't think we've really quite got our heads around that. We're still in the model that if we can get one person to do it...
This is for the actual people got with the jobs, or is this for the trainees?
Well, let's start with people for the jobs, because at the moment we don't have a nucleus of that workforce there to train the next generation. We're training them, as we can with ageing professionals.
So you're moving towards, say, the Queensland model, where you don't assume they're going to come in as a private practitioner, or they're going to come in as a salaried practitioner, and you supply a bit of living infrastructure for them.
And if you look at allied health professionals, their scope of practice, it's obvious that it's going to need to be supported.
And we need to go beyond just, again, seeing it as a health issue. When we talk about speech pathologists, one of the great assets is working with kids, in the school system. And if we want to improve education outcomes, we need to start very early, as the Australian Literacy and Numeracy Foundation does, with speech pathologists working with the community to give them the early start.
So I'm the health minister, I'm the federal health minister, and I'm saying that's a state problem. I'm not going to pay for it.
And what we're saying to you is the lack of integration and the fact that we still don't have hooked up programs is a major part of our frustration. Because it's all of our problem.
So what does the health minister do?
So they continue down the line of accountable funding programs that blend care and blend responsibility.
Is there somewhere where I, as the health minister, can take money to put it into that blended payment system that's going to be a trade-off, or you're looking for new money?
I think that we are on the way, perhaps with some of the Medicare locals and local health districts working together, that we're actually on the beginning of that journey of whether we start to share health priorities and share accountability for health outcomes. So I think with the right environment, we're already starting to see some of that development. We just need to see it on a regional basis, and we need to see it supported over time.
Have you answered my question?
Probably not.
So the trade-offs?
So where can we take money from in order to fund a hooked up arrangement?
Is there somewhere where I'm going to save money that I can redirect in here, or is there money already going to some of these resources which could be better spent?
Well, that's what I'm suggesting. What I'm suggesting is that you look at the accountability of the local health district, and you look at the accountability of the Medicare local, and you give them the same
reconfigure
same outcomes to work towards. And that's what I'm talking about.
And I think if you reconfigure it in a service learning model, so that you've got a combination of service delivery and workforce development. And so you combine the specialist allied health, so the people who are higher skilled and more experienced with a lesser experienced, and students. And so you have student assisted clinics, so you actually get much bigger bang for your buck. And you reconfigure the work so it's more of a supervision, support and spread.
Tom, has the trend towards rural generalists in, say, particularly Queensland, to a lesser extent in WA, and to some extent now in New South Wales, that sort of kind of super specialist general practitioner, largely through the College of Rural and Remote Medicine, is that hitting Aboriginal communities, community-controlled organisations, or are they still in an older general practice model?
Well, Sabina's probably best placed to respond to that in the sort of experience that she has. It's not something that I can talk about with any sort of authority. But you know, just picking up on your issue about what the health minister should do, and I think that's called together all the health ministers. They have the health ministers forum. They do have their senior advisors. They do have the COAG system to be able to sit down and look at these priorities and make sure that we get back down very clearly to a needs-based funding model that's very regional and not just the one blanket approach that exists too often around at the moment.
Well, we're almost out of time, so I'd like to hear what the elevator pitches, key messages for the health minister on the 15th of September. Sabina?
Well, I've got two messages. One is leave the national architecture alone. It's new. It's not all new.
So this is Medicare Locals, local health networks,
we've got we've got Health Workforce Australia, we've got the Prevention Agency, the Pricing Authority, the Performance Agency, NHMRC. All that national architecture is really important to be joined up. Some of it's too early to change. We need to keep that and keep our, at the regional level, improve our data so that we are able to, at the local level,
on this
plan,
needs basis that
know
Tom's
what we're
talking
doing,
about.
know where we're going, and know where to redirect our services if we need to.
And trust local people to get it right, rather than directing
Yeah,
them
and
to
look, some of us will make mistakes, that's fine, but the important thing is that we know that you're making the mistake and redirect in a timely way.
Tom?
I think it's just high time we stop continually consulting people and start to listen, and that's critically important. Because
So you mean stop talking to people, shut your mouth and listen. The consultation is the one way.
And don't go out and ask them again what they want. That happens too often. There's too many reports out there. Let's just concentrate on what we've got.
Very briefly, Jenny?
Well, building local models, and I think the rural pipeline, the generalist program is one example of a rural pipeline that I think we can be more strategic in hooking up the investments.
Alison?
Let's move away from this, 2-year funding model. Let's get some longevity into our funding and investment into mental health in
God,
rural
you're an
areas.
idealist.
Yes.
Well, thank you all very much.
Thank you,
It's
Norman.
been very instructive.
It's been great.
Look, if you're interested in obtaining more information about the issues raised in tonight's programme, or you'd like to watch it again, which I'm sure you must, please visit the Rural Health Education Foundation's website, rhef.com.au. And what you do then is you click on the Rural Health Policy into the Future programme webpage. Our thanks to the Australian Government's Department of Health and Ageing, presumably there will be one after the election, for making this programme possible, and to all those who've helped in its development. But above all, thanks to you for taking the time to watch and contribute to our discussion today. We'd like to hear from you, so send us your feedback on the programme, because your comments are important to us to constantly improve our service. Send us an email or a text and share your views. We'd love to hear from you. I'm Norman Swan. Goodbye, and join us again soon on the Rural Health Channel.